Good morning, and thank you everyone for joining us for this FDA CERSI workshop on prenatal somatic cell gene therapy. My name is Tippi McKenzie, and I'm a pediatric and fetal surgeon at UCSF. I direct the Broad Institute for Regeneration Medicine, where my lab develops and tests prenatal therapies for single gene disorders, including stem cell and gene therapies. I'm also the co-director with Dr. Mary Norton of the Center for Maternal Fetal Precision Medicine, which is a multidisciplinary group designed to accelerate the clinical applications of new therapies to patients before birth. These are my disclosures. So this conference is the culmination of numerous conversations and research meetings between the Precision Medicine Center, members of FDA CBER, including Larissa Lepteva and Evie Struble, and CERSI. So I'd like to thank the members of our organizing committee and our collaborators. And all of this was made possible by the careful attention to detail of Val Doherty, the program manager for the Center for Maternal Fetal Precision Medicine, and Lawrence Lin from UCSF CERSI. Thank you all. I also want to thank all of our speakers for partnering with us to create this program, which will go over the various scientific, clinical, ethical, and regulatory aspects of prenatal somatic cell gene therapy for fetuses with severe early onset genetic diseases. We hope to generate dialogue around these sessions, so we have designed some panel discussions, and thank you to our panelists and moderators for joining us today, as well as our parents. We are here today because of the merging of these three roads of fetal therapy, prenatal diagnosis, and gene therapy. We happen to be living in a golden age of medicine where we have the ability to diagnose and repair almost any typo in the genetic code. Along with this, we have the ability to diagnose genetic diseases before birth and the surgical techniques to deliver these reagents to fetuses safely. So how can we translate this into a safe clinical application for prenatal gene therapy? Our objective today is to discuss the scientific background and rationale for prenatal somatic cell gene therapy for severe monogenic diseases and start a dialogue regarding a safe regulatory path for a phase 1 clinical trial. It's important to note what we are not considering in this meeting. We're absolutely not condoning editing in embryos or germline editing that can be heritable for future generations. Prenatal therapies are generally applied in the second or early third trimester, and these would be for severe life-threatening disorders with a clear unmet medical need. We're also not talking about ex vivo editing of fetal cells for retransplantation, because that doesn't appear to be feasible with current technologies. So there are a lot of considerations when thinking about a new therapy given before. So broadly today, we're going to cover some background in the field of fetal surgery, which genetic diseases and therapeutic modalities could be considered for prenatal therapy, and the background on the state of prenatal diagnosis of genetic diseases. In session 2, we'll go over some of the most relevant preclinical data in animal models. And in session 3, we'll focus on one candidate disease, SMA or spinal muscular atrophy, as a proof of concept, as well as going over some regulatory and ethical considerations for prenatal gene therapy in general. We'll end the day with a final capstone panel discussion. One of the most important voices in these discussions is that of our parents. So to start our first session, we're going to hear from two parents, Hunter Howard and Grace Peng, each of whom experienced the pain of receiving a prenatal diagnosis of a severe genetic disease in their fetus. And since these are inherited diseases, in multiple pregnancies. Each can speak to the process of thinking about a new fetal therapy, the risk-benefit calculations, and barriers faced by patients. The interview is conducted by Billy Liagnoglu, our genetic counselor. This conversation illustrates, among other things, the responsibility we have to these families and the multitudes they represent to develop better options for these rare genetic diseases, and the hope and optimism of these parents that we as a field can meet this challenge. Thank you.
Hi, everyone. My name is Billy Liagnoglu. I'm a genetic counselor. I work at the University of California, San Francisco Fetal Treatment Center and support the clinical trials from the UCSF Center for Maternal Fetal Precision Medicine. I have the pleasure to be joined today by two mothers, both of their children affected by single gene conditions that may in the future be impacted by in utero gene therapy. Our first mother, Miss Grace Pang, has a daughter, Sophie, with alpha thalassemia major.
Hi, my name is Grace Pang Trong, and I'm a mother of Sophie Trong, and she has the condition called alpha thalassemia major. Prior to having her, I did have two previous pregnancies. The first one having a lot of structural abnormalities that we had to terminate early on. And then the other pregnancy with Isabel, she also had unknowingly alpha thalassemia major as well. We did not know at that time that we had the condition. So I carried her up to around 32 weeks. That's when we found out she had the condition and had emergency C-section. By the time she was born, she was already very sick with major hydrops, and she passed away 11 days after birth. With Sophie, we knew going in of the potential risks, so we did testing prior to that as soon as possible. So we did the CVS as early as possible and found out that she too had the same condition. And we sought for intervention and had in utero blood transfusion, 5 of them total, and was able to deliver her at full term at around 38 weeks. And then followed by my youngest, Hannah. At the time, having gone through with Sophie, knowing kind of everything and the risks going in, we knew exactly who we would go to if things were to turn out the same. But fortunately, she did not have the full condition, alpha thalassemia major, although she does have the trait itself. So she's 1.5.
Thank you, Grace. I'd now like to introduce Hunter Howard, the mother of Skylar and Angel, both of whom had a diagnosis of mucopolysaccharidosis type 7.
My name is Hunter. I had 2 daughters who were diagnosed with mucopolysaccharidosis type 7, also known as SLY syndrome. My first daughter, Skylar, was born at 32 weeks due to extreme hydrops. We weren't really aware of her condition, never heard of it before. When we got her formally diagnosed at 5 months, she started to receive enzyme therapy, which we noticed a major change in her physical and even her neurological developments. Unfortunately, she did pass away at 10 months due to a blood infection. I did get pregnant again with another girl, and we knew what the chances were of her being affected as well. So we did the CVS at around 9 weeks and received the results that she was also affected by SLY syndrome. She didn't get to make it as far as Skylar did. I did have her stillborn at 28 weeks. I was really excited because after the diagnosis, we were introduced to Billy and her team to potentially get the enzyme therapy in utero to see if that could potentially lengthen her time in the womb, because they didn't think that she was going to make it all the way or even make it to birth and potentially thrive and get to live a semi-normal life. But unfortunately, we didn't get a chance to get there. But now I do have a son named Santana. I had CVS again at 9 weeks, got the results back 5 weeks later, and he is completely unaffected. He doesn't have the trait, doesn't have anything. So I won't have to worry about that becoming an issue for him at all.
I would like to start with you, Hunter. As we connected during your second pregnancy when you were carrying Angel, could you explain what you thought when you learned of the possibility of coming to California and the potential for being the first patient to undergo a specific intervention of in utero enzyme replacement therapy?
Well, I was really excited to be a part of something so new and experimental. I was really willing to put myself out there, whether it worked or not, because you guys would be able to know if if it did work, then it'd be able to help save other people. And if it didn't work, then you guys would be able to see what didn't work about it, and then be able to go back to the drawing board and see what you need to do in order for it to work for someone else. So I was just really excited to be able to help in one way or another. But some things that I were considering were kind of like, what would it consist of? How long would it take for results to be seen, if it was going to work or not? And could it potentially, I guess, like, could it terminate it in a way if things didn't go right? So those were some things that I was considering, but I think that the good would have outweighed the negative on it. So I definitely would have loved to participate in.
Thank you, Hunter. And what barriers or concerns did you face both in your history and diagnostic journey with Skylar, and then later with Angel, and then also in considering to uproot yourself and come to California from North Carolina?
There was definitely a lot to consider going all the way out there. Like, I had a job that I have, like, you know, like monetary obligations like rent and bills and stuff like that. And at the time I didn't have like what we would consider short-term disability for me to be able to go out there and still be able to get paid for being there. So that definitely put a damper on things, and I had to see how I would have been able to work all of those obstacles into going out there.
Hunter, you know, I also wanted to talk about another conversation we had where you asked me about gene therapy and if it would be an option for SLY syndrome. And how would you consider that, you know, if you did have the option to pursue gene therapy? And what would you need to know to participate in a study looking at in utero gene therapy for the treatment of SLY syndrome as you expand your family, if that were to come about?
I would definitely want to know kind of the ins and outs of it. What would it consist of? Again, how long do you think that we would have to participate in order for results to be seen? If it doesn't work, then what would be your other options for me or suggestions for me? Kind of what are the risk factors of doing so? But if I was offered the opportunity, though I would have a lot of questions about it, I would definitely jump at it without a doubt, because it doesn't hurt to try. When you've tried everything, you run out of options. If that's something that I would have to participate in, just to get even a small chance, a 1% chance is better than nothing. So I would definitely want to participate in that to give myself and my child a chance at life.
Thank you so much, Hunter. I think, Grace, you're in a similar but different situation because Sophie's condition is manageable. You know, you've been through a pregnancy with transfusions, and you know what it's like to manage her diagnosis now with her serial transfusions and other therapies like iron chelation. So what thoughts would you have about the potential option for in utero gene therapy for alpha thalassemia major? And what do you think you would need to know given the risks and benefits, or what would you want to know in general about that intervention?
Yeah, I think if opportunity, arises for, I think I would definitely take that up as consideration and really think about it, and really consider it, given that everything that I've been through with the various pregnancies, I've kind of been through all different avenues with no intervention at all, which we know the fatality rate is very high, with intervention, with the blood transfusion, which requires chronic transfusion. And, while that is, Sophie's thriving, but, it's not, her condition still exists today. I mean, it's with her for the rest of her life. If there was gene therapy in utero available at that time for Sophie, I would definitely consider it, thinking back retrospectively, because, if there was an opportunity for me to help my daughter correct the condition and reverse it and even prevent it, then I would definitely want to give that a try. In terms of what I would want to know, similar to Hunter, I mean, I want to know kind of the data part of it. I know it would be a novel intervention, but, with whatever data to kind of support what we have to see, how doable is it, the risks, the long-term and short-term side effects. So that way I know going in the risks that are involved. Of course, there's, going to be various side effects, as I would assume, but, to see if it would be worthwhile to consider versus the chronic management of this condition that we're doing today. But again, if the opportunity were to be provided to me, I would definitely consider that, given that if there's a chance for me to prevent my daughter from having to get blood transfusion every 3 weeks for the rest of her life, and not have to be on chelation medicine, which has side effects, then I think definitely it's a positive. It would definitely get my attention to want to pursue that route.
Thank you, Grace. I think we have the opportunity to engage the community that's listening today and those that will watch in the future. And while we have everyone's attention, I just wanted to give both you and Hunter an opportunity to give any other thoughts you have about in utero gene therapy and in utero interventions in general when considering these very complicated single gene diseases that you've both had experienced such intimate experience with.
Oh, well, I would like to draw attention to these single gene disorders. I don't think they get recognized enough, or they don't get enough attention or value because they don't happen that often. It's not like a sickle cell, or it's not like a Down syndrome, where it's something that's more common. So people kind of throw those to the side. I really think that insurance companies should cover testing and infusions for it and treatments of all kinds for all children with these disorders, because they don't ask to be here. They don't ask to be born that way. And there's nothing that we could have done to prevent them from being this way. So I really think that we should put more thought and more attention and more funding and more research into ways to make their lives a little better, or even if it gives them a chance to live. I think that we should put more research and more funding and more attention into these things, so we'll be able to make sure that families don't have to go through the things that we've been through, because it's really hard to get through, but you keep pushing, and you just hope that one day this will be a thing of the past, or even if it does come up, we'll have treatments for it where we don't have to worry about what are you going to do, or what. There's no, oh, well, this is just, we're just going to give you a status. There's nothing else that we can do for you. We'll actually have treatments, and we'll have resolutions instead of just questions with no answers. So hopefully what they take away from this will be able to help other families be able to get the access to treatments and to testing, and that we can make genetic disorders something that we can get over and get through, instead of just making them a stop sign at life.
I'm very excited to kind of see where the next steps are in terms of in utero gene therapy, because I think that definitely will open up avenues of all kinds for all kinds of genetic treatments and disorders for a lot of babies' lives to be saved, and a lot of families and parents to not have to go through a lot of pain and heartache and just difficulties and struggles that that we had to endure, or that previous parents had to endure. So very glad and excited to see what the next chapter brings in terms of gene therapy.
Thank you both so much for your time and insights. We look forward to the future together. And certainly I think everyone will keep in mind your stories and those of all the other families that have similar loss due to these rare diseases. Thank you so much for your participation today.